Hi, I'm Claire Ritchie. I'm the Director of Hospital Services for Wishaw.
Hi folks, I'm David Watson and I'm the Chief of Nursing based here at University Hospital Wishaw.
And I'm Dr. Kent Dack, I'm the Chief of Medicine at University Hospital Wishaw.
Due to Wishaw's continuing pressure, we have had a whole system approach to the mini fire break this last week, where we have worked with colleagues from district nursing, from children's services, community nursing and mental health. We have had hospital home in our EDs pulling out patients, and our focus has been to work together to review every patient to ensure that we have any possibility of optimising discharge and facilitating the best option for that patient, being home or otherwise. We've also worked with social work colleagues and home care, the hospital HAT team. So it's been a huge amount of energy, lots of people. It's been hard in relation to challenging questions, challenging each other from a professional perspective, and I suppose learning every day in relation to what we might change. And some of the things we've changed are in relation to looking at interim care beds or asking for specialty assessment for some of our patients. It's highlighted some real gaps in our system, and some of them are honestly space and workforce, and then escalating that up to the senior executive team. So some of this key learning we hope to take forward as a whole system with colleagues in the planning for the operational flow in February.
So Claire's already touched on the fact that although we are based here at University Hospital Wishaw, this is a whole system approach, and one part of that puzzle can't solve the challenge we've got, which is an unprecedented challenge regarding capacity and demand. So in the lead up to the fire break, because I don't think we can underestimate the amount of work and involvement with our staff on site and our partnership colleagues. I'd like to just thank those staff for the massive involvement this week, because it's taken a phenomenal amount of work. However, our vision for what we could try and achieve this week was very much born from, for the several weeks now into months, we've had our partnership colleagues once a month come on to do a day of action review. And what that entails is we've got partnership colleagues from social work, physio, OT, mental health, paediatrics, health visiting, all coming on site to look through a different critical lens. We've got a massive array of expertise across NHSL. It's about us pulling that resource together to look critically, to think what can we do differently. So on those day of care actions, we would review every single patient in every single ward, as in what was their planned date of discharge, what are the barriers to them going earlier, and the driver with this is getting the right patient to the right place, and for the majority of our patients that right place should be their home or their longer term care facility, whatever is required for them. Every day patients are in hospital, there is increased risk for patients, we know that, and that's well sourced across all the evidence base and the literature and the resources out there. So our drive through those day of actions is to try and mitigate and overcome any of those barriers are in place, preventing our patients getting to the right place. But that takes a multi-agency approach, and Claire's already touched on a lot of that about the facilitation and transfer of patients to interim care beds. It's also about working with our patients and their relatives as well, and their loved ones, to make sure we get them to the right place. So I'd say the big thing for us leading into this fire break was our day of action, because rather than that focus, prior to that, the focus was very much on the site and what can we do, but staff on the site are working exceptionally hard, and the solution for this needs to be beyond just site base. So the day of action reviews allowed us to build those relationships and more collaborative working. So I'd say that was one of the biggest things we were proud of, in the relationships that we are building with our colleagues, which will stand us in good stead going forward. And I'd continue to ask for their ongoing support regarding taking this forward as well.
So obviously we're still in the preparation phase, but Operation Flow is a real opportunity for us to look at our entire healthcare system and our systems on the site to deliver the best care for our patients. And we know that the best care is often delivered at home. So what opportunities do we have as a site to facilitate earlier discharge of our patients from our continuing care wards, whether that's medicine, care of the elderly or orthopaedics. What opportunities might we have to limit patients' need to attend hospital? So we can use devices like Prof to Prof, where we can use senior decision makers to discuss the need for admission or attendance at hospital with our partners in the community, whether that's the ambulance service, whether that's district nurses, or whether that's family doctors. And these are the things that we're really keen to test. We're looking to augment many of the services that we already deliver. So the ability to use hospital home for more hours in the day and more days in the week will provide opportunities for patients to be seen, assessed, and hopefully treated at home. We're also looking at the potential for radiology investigations to be facilitated with easy access for family doctors and community staff, avoiding the need for patients to come to the ED department. So there's a whole range of proposals that we've got that we're working through with our staff on the site and the community on this site to try and maximise the opportunities within Operation Flow.